Uh, Oops. Thank you very, very much. It is a great pleasure and honor to introduce Dr. Victoria Vetter today to Grand Rounds for Critical Care. Dr. Vetter is really one of the true pioneers in the field of pediatric cardiology, as well as pediatric electrophysiology, as she really is one of the very first full-time electrophysiologists in pediatrics in the world, and also one of the first women who have risen to the absolute highest levels of our field, and is now, of course, universally recognized as one of the single most important cardiologists of the past half century. She's a graduate of the University of Kentucky College of Medicine, completed her residency at Johns Hopkins and Vanderbilt University, and completed her pediatric cardiology fellowship at the Children's Hospital of Philadelphia. She's also has a master's degree in public health, health policy, and health services research from the University of Pennsylvania, and is the former chief of pediatric cardiology at the Children's Hospital of Philadelphia from 1993 to 2007. Dr. Vetter has received numerous awards for her work in pediatric cardiology, including the Young Investigator Award from the American Academy of Pediatrics and the Heart of the Child Award from the CARE Foundation in 1996. In 2002, she was awarded the Distinguished Alumnus Award from the University of Kentucky Medical Alumni Association. And in 2003, she received the Evelyn Rome Tabas Endowed Chair in Pediatric Cardiology at the Children's Hospital of Philadelphia. As I've already mentioned, she is a leader in the area of pediatric electrophysiology, is particularly well known for her expertise in long QT syndrome and other genetic conditions associated with sudden cardiac death. She is the medical director of Youth Heart Watch and is the chairperson of the Medical Advisory Board of Parent Heart Watch, which is a national organization of parents who aim to prevent sudden cardiac arrest. Today, Dr. Vetter will be addressing us in a talk entitled "When Laws Save Lives: Impact of Legislation Requiring Cardiopulmonary Resuscitation Education in High Schools." Vicki, welcome to Grand Rounds. So happy to have you.
Thanks so much, Rob, and thanks for your introduction. Let me see if I can manage this virtual sharing of my screen, and then we'll see if we can start. Can you guys see this?
We can.
Yes.
Yes.
Great.
Okay. There. All right. Let me know if this stops working at any point in time, or if you can't hear. There's a video. Elba checked it, and I think we're okay. But we all know how this remote education goes. So it's a real pleasure to be with all of you, albeit virtually, to speak about this topic on the impact of legislation requiring cardiopulmonary resuscitation education in high schools. To give you an outline of the presentation, I will provide some background on sudden cardiac arrest, facts, and its scope as a public health problem, the impact of bystander CPR on survival, methods of increasing bystander CPR and AED use, the impact of legislation on bystander CPR and AED use, barriers and disparities in both bystander CPR and AED use and education, and perhaps potential solutions. You all know that sudden cardiac arrest happens when the heart suddenly and unexpectedly stops beating with immediate loss of electrical function. The electrical abnormality causes the heart to fibrillate, as shown here, and blood flow to the body and brain stops. And without intervention with CPR and AED use or spontaneous recovery, which is rare, sudden cardiac death occurs. The mechanisms of sudden cardiac death include ventricular fibrillation, pulseless electrical activity, and asystole. Sudden cardiac arrest is a leading cause of non-accidental death in youth in the U.S., accounting for about 75% of all athlete-related deaths. It is also the leading cause of death on school campuses, with about 1 in 70 high schools having a sudden cardiac arrest annually, with half of these being in students and the rest in visitors, staff, teachers, and so forth. There are about 23,000 child cardiac arrests annually, but we don't know the number of deaths because there is no registry for this. Sudden cardiac arrest affects all children, as all children are active, although they are not official athletes. Sudden cardiac arrest can be treated by CPR and AED use, but it is a catastrophic event with a very low survival rate of about 10 to 11% in both children and adults, and with a lower rate of neurologically favorable survival, which is generally classified as a CPC of 1 or 2. Thus, prevention of sudden cardiac arrest should be our goal. Excuse me. Sudden cardiac death is most common in the 10 to 19 year age group and more common in males than females. 2/3 occur with exercise or activity, with an incidence shown in this chart of from 13 per 100,000 person years to 0.6. This is a frequency of 1 in 8,000. This was in the military, or 1 in 167,000, mostly using media reports. But the most accurate data probably come from this study by Diane Atkins using Resuscitation's Outcomes Consortium data, excuse me, which showed that approximately 8 per 100,000 children will have sudden cardiac death annually. What causes sudden cardiac arrest? We know that it's an abnormality in the electrical system and the heart structure or function. Over half to 3/4 of the time, it is not diagnosed prior to the arrest. Warning signs and symptoms do exist in 30 to 50%, but are ignored or misunderstood, particularly by young people. This may include fainting with exercise, chest pain and/or shortness of breath with exercise, palpitations with exercise, extreme fatigue. Many of these conditions are inherited, but family members are often unaware of their family history. This slide shows the heart conditions associated with sudden cardiac death in children from a database from Parent Heart Watch, and indicates some of the genetic causes. The most common is cardiomyopathy, with hypertrophic cardiomyopathy being responsible for about half of the sudden deaths in young people, but others, right ventricular cardiomyopathy, dilated cardiomyopathy, and LV non-compaction. Primary electrical disease, and especially autopsy negative sudden unexpected death, is very common, being mostly due to long QT, Brugada, catecholaminergic polymorphic VT, CPVT, and a small percent associated with Wolff-Parkinson-White syndrome. Congenital heart disease, particularly in the postoperative state for specific conditions, Marfan syndrome, coronary artery anomalies. This is not atherosclerotic coronary disease, but rather anomalous origin of the coronary artery, such as the left from the right coronary sinus having to travel between the aorta and pulmonary artery, or from patients who have had Kawasaki disease in the past. Acquired heart disease, we've seen more myocarditis recently, particularly in association with the COVID pandemic, a number of drugs, and then commotio cordis, or an inopportune blow to the chest. The frequency of these conditions ranges from 1 in 500 for hypertrophic cardiomyopathy to about 1 in 3 to 5,000 for most of these other conditions. That results in a prevalence of 0.2 to 0.4%, or every 1 in 250 to 500 youth has one of these conditions, albeit in many cases silently. Who is at risk for sudden cardiac death? Well, we know that there are 70 million children. Half of them are on athletic teams or in individual sports, which includes 12 million high school athletes. But there are 35 million children who are not on sports teams, but they are very active. In the child and adolescent population, there are those with known congenital heart disease, but there are many with undiagnosed cardiac conditions. There are those who will have exposure to drugs, medications, toxins, or infection agents in the previously mentioned commotio cordis. And 10 to 15% of sudden infant death or sudden unexpected infant death are from mutations that cause long QT, CPVT, or Brugada. The risk factors for sudden cardiac arrest include a family history of a known abnormality or sudden cardiac death before 35 to 50 years of age, depending upon the publication. This would include a family history of long QT, Brugada, hypertrophic cardiomyopathy, ARVC, or other congenital heart disease, particularly left-sided obstructive lesions, or family members with unexplained fainting or seizures that may be due to one of these conditions. Further use of drugs such as cocaine, inhalants, recreational or club drugs, or high caffeine drinks, or many of the workout supplements contain a high amount of caffeine. We recognize sudden cardiac arrest when the person passes out. And we think this may be easy, but in the hospital, we're primed for that in a situation where people are on the street. This is less expected, and thus, when the person suddenly passes out, they appear lifeless except for abnormal breathing. This often fools people because they may be gasping, have rapid or irregular breathing initially, or seizure-like movements from having inadequate brain perfusion. But the sudden cardiac arrest victim is unconscious and needs immediate help. If nothing is done, death will occur within minutes. Thus, prevention is important. This can be either primary prevention, where we optimize screening, identify and treat high-risk children and youth, or secondary prevention with CPR, AEDs, or implanting an ICD. Survival from sudden cardiac arrest requires immediate intervention, frequently from bystanders like you. One has to activate the chain of survival by calling 911, have rapid CPR, and as every minute of delay after sudden cardiac arrest decreases the survival by 10%, and have prompt treatment that could save 40 to 80% of those experiencing sudden cardiac arrest. This video is of a student in a high school outside of Philadelphia who was revived about a year ago, and with a small comment from her parents. Oops. Let's see if I can make this work. So the problem is that there are 380,000 sudden cardiac arrests a year across this country, 23,000 of them, as I previously mentioned, being in a child. We do know that 20% of the population is in a school on any school day, not just children, but community members who use the school and school staff, as well as visitors. The solution then is increased bystander CPR and AED use. But currently the bystander CPR rate ranges from 20% or less to 87% in adults, and probably an average of about 40%, and 50% in children. This has been increasing over time since the AHA and ILCOR recommended a compression only or hands-only CPR. Bystander CPR doubles the odds of survival, which increases further in the presence of a shockable rhythm. Broad deployment of AEDs and increased bystander CPR by only 20% could prevent as many as 50,000 deaths each year. But does this work in children? In Norway, where there's 73% bystander CPR, remarkably, they have a 52% survival rate. In Denmark, when there is bystander CPR and a shockable rhythm, the AED survival and use of an AED survival is between 69 and 74%. And we found, and this was in 2014, and it's a bit higher now, but the presence of an AED in school improved survival to 64 to 74% if it was applied within 3 to 5 minutes of collapse. We know that AEDs can safely be placed in schools and other public areas, but this study of U.S. high schools by the group who worked with John Dresner and his group, who used the National Registry for AED use in sports, showed that survival of witness arrest in schools with an on-site AED is high, up to 89%, both in student and adult athletes using the facility, especially when there's a cardiac emergency response plan in place and prompt CPR is performed. So contrast this with the survival rate of 10 to 12% on the streets. And you can see why it's important that we have people in schools who know how to do CPR and use an AED. But what about other places? This is just a recent publication in the British Journal of Sports Medicine that was a meta-analysis using 29 students looking at bystander CPR and AED use in exercise-induced sudden cardiac arrest. And they found that there were predominantly males, that the age was a median of 51, that they had a shockable rhythm in 78%. So this is kind of the best case scenario. They received bystander CPR in 71%, AED use in 31%, and their survival to hospital discharge was 32%. So their key message was that bystander CPR and AED use are related to favorable outcomes after exercise-related sudden cardiac arrest. To improve outcomes after this, universal emergency planning, layperson education, and CPR and AED use, and the availability of AEDs in key activity spaces should be prioritized. But how do we prepare the public to be lay responders when only 18% report annual training in CPR? And this decreases with the increasing age of the bystander. Training is associated with a fourfold willingness to perform CPR, but current training focuses mostly on psychomotor skills, which is necessary, but factors that affect the willingness to perform include a sense of obligation, a feeling of competence, the courage to respond. Most current courses don't focus on these emotional aspects of providing CPR or its aftermath. Further, current training methods are not well validated for efficacy or for retention of skills. Video-based or image-based training is as good as instructor-provided CPR training, and peer instruction has been shown to be as effective as health provider instruction. Also, there are alternative methods such as video-based, smartphone, or virtual CPR that sometimes appeal to the younger and current learner, and we should therefore consider novel educational and advanced technology in training approaches. This is a program, Project ATOM, which stands for Automated Defibrillators and Adam's Memory. This began in 1971 when Adam Lemmel, a 17-year-old Whitefish Bay, Wisconsin high school student, collapsed and died while playing basketball. He had suffered a sudden cardiac arrest, but there were no defibrillators in the school, and it took EMS a while to get to the school. His parents and friends collaborated with Wisconsin Children's Hospital to create this program in his memory. We had already created a program in the early 2000s to work with the Philadelphia School District, and we called our program Youth Heart Watch. But now there are 38 affiliate sites in 29 states, and I would advise that you go to this website to see just what is available. And this is one of the programs you will find under this Heart Safe School tabs. In 1926, we formalized the Heart Safe School program that has implementation process that is outlined on the website with a checklist and a 3-year renewal process. These are the 14 steps to Heart Safe School designation with 5 categories, including automated external defibrillators, placement, signage, and awareness of where the defibrillators are in the school, a cardiac emergency response team made of a number of individuals who will always be present in the school, a cardiac emergency response plan that's written, that is communicated, that connects with local emergency medical services, training of individuals within the school, awareness of where the AEDs are, and awareness of what a sudden cardiac arrest is for all faculty. And then very importantly, and this is probably the hardest part of this designation, is that they need to perform a cardiac emergency response drill, preferably in connection with their local emergency response teams, so that they will be prepared just as they are for fire drills and for an active shooter. Now, getting on to teaching CPR to school children, this is an excellent article by Nina Plant and Catherine Taylor. It's from 2013, but I don't think there's anything better that's been put out. It really outlines the full potential curriculum for children, stating that children can learn CPR at an early age at 4, where they can call 911 and recognize an emergency. Middle school children around 10 years of age can learn CPR and AED skills, but their compression depth correlates with their upper body strength, particularly, and with their size. They need hands-on practice, as all of us do, and repeated training improves their skill. They can use variable instruction methods, including self-instruction kits, computer-based learning, and teacher and peer trainers. And this manuscript recommends that legislative and funded mandates be developed for training for a longitudinal framework over the entire school career, where there would be multiple opportunities to learn and reinforce the skills of CPR and AED use. Well, why should we train children? Well, this would mean that we are training a large population in school that will create a generation of adults who know how to perform CPR. It will increase the importance and awareness of sudden cardiac arrest in early life. It will be training at a time when learning is the main activity. It will provide life-saving skills as children and adolescents are becoming more engaged in public life and employment, considering jobs such as being lifeguards and babysitters. They're likely to have appropriate physical fitness to perform CPR and more likely to automatically respond in an emergent situation, being less inhibited than many adults. CPR education can be distributed across cultural, social, and ethnic groups because all go to school. It has been shown to increase self-esteem, introduce social responsibility, and normalize a response to an emergency. And it can extend the information and training materials to others in the home. So it has a multiplying type of benefit. This is a survey study of CPR instruction in high schools from 2017 that showed that CPR is taught in all grades, but most commonly in the 9th grade, most commonly in health classes, most commonly by teachers or coaches who use a variety of training methods, but more commonly American Heart Association, American Red Cross methodology, 97% of the time using hands only or compression only CPR. 77% also included AED training, which should be 100%, of course, and only 8% required certified instructors to teach the students. So that doesn't need to be a barrier. We decided to see if there were other potential methods that could be used to teach CPR and AED use in schools. And we developed this program called SPORTS that was supported by American Heart Association and Laerdal Foundation grant. And it was student program for Olympic resuscitation training in schools. And we owe that acronym to Lance Becker, who many of you know is out on Long Island now. This was a study within the Philadelphia School District that began in 2010. We included 15 Philadelphia high schools. In each class, each school, there were 2 9th, 12th grade, depending upon when they taught it, classes selected 15 to 30 students per class. There was a control class that used their usual CPR program, and they didn't participate in an event we held that I'll explain in more detail that we called the CPR and AED Olympics. The study class included used their usual CPR program at their school. They developed innovative new ways to learn and retain the skills of CPR and AED use and to teach their peers. And the students themselves thought up these programs. They were incredibly creative in the different ways that they developed to teach CPR and AED use. And then they participated in our CPR and AED Olympic event at the end of the year and presented their programs to the other students and to us. This was held on Franklin Field, which is the University of Pennsylvania football and track field on our campus. 13 schools participated in 5 events that included presentation of their programs, a mock arrest that we graded for 19 different factors that they needed to perform, and the average score was 93%. A compression challenge that looked at rate and depth of compressions, a 2-minute turnaround that was to simulate an arrest in a school, and then a relay where they used a baton that was an AED to run around the track and hand off CPR to their classmates. And we chose the winners on a composite score. They were tested in school before and after cognitive testing, after their program for cognitive testing, psychomotor skills, mock codes, willingness to perform, and their presentation scores. It just shows psychomotor tests that showed that everybody, they didn't know how to do much to start with. They improved whether they were in the control of the study class, but we only were able to look at 6 schools before and after, and we found that in the schools that had come to the CPR AED Olympics and had developed their own programs, they had remarkable retention of their psychomotor skills. So this is, I hope, going to show you just a little bit of what the event was like on that day. It's just about a minute. They marched into the Olympic set by the fanatic. This was a compression challenge. Had a good time too. This was a presentation. This is Bo Kimball, who was Hank Gather's friend. Some of you will know who that is. Song was written by one of the students. Incredibly talented. So I apologize for the audio, but I just wanted to give you an idea of what this kind of novel program was about. And the students were really amazing. So we concluded that participation in CPR and AED classroom learning significantly increases skills in all areas: cognitive, psychomotor performance, and willingness to perform. The retention of psychomotor skills was excellent in both groups, but significantly enhanced in students who developed their own educational programs to teach their peers and who participated in the CPR and AED Olympics. So now I'm getting to perhaps what you'd like to hear about. And I promised to tell you, we published this study in the Journal of American College of Cardiology a little bit earlier this year on their cardiovascular medicine and society section and the impact of state laws, particularly CPR education in high schools. This is the American Heart Association legislative map online. We know that requirements for CPR and AED training in schools are determined at the state level, leading to nationwide variations in legislative mandates. The red states are those that have state laws. While mandates for CPR and AED education have been present since as early as 1984, there has been a recent upsurge in the number of states requiring CPR and AED training, and currently 39 of the 50 states, plus the District of Columbia, require CPR and AED education for high school students, some for graduation, most just that it be in the curriculum, while the remaining states have no legislation. To assist us in our study, we used the Cardiac Arrest Registry to Enhance Survival, or CARES. In 2004, CARES was established by the CDC and Emory to improve survival from cardiac arrest through data collection in the United States. Communities that join CARES enter data from EMS agencies and hospitals, and they track their performance and benchmark it over time to improve patient care and increase survival. There are statewide registries in 23 states and 63 community states in 18 other sites in 18 other states, which represents a catchment area of about 115 million people, or 405,000 patients at the time of this slide. This is a map that shows their catchment area, the states and the various sites. And this is just one page of their registry questionnaire, which includes questions such as who performed the AED shock and was an AED applied prior to EMS, and many other questions that investigators can use. We hypothesized that CPR and AED education mandates would improve bystander CPR and AED use rates, survival, and favorable neurologic outcomes in victims of sudden cardiac arrest, and might decrease current disparities. Our aim was to determine and compare the effect on victims of sudden cardiac arrest of statewide legislation requiring CPR and AED education in high schools, on bystander rates, AED use rates, survival, and favorable neurologic outcomes, although I'm mostly going to report on bystander CPR, between states with and without legislation from 2013 through 2020 by age, sex, race, ethnicity, location of arrest, urbanicity, and neighborhood socioeconomic status, or SES. Our outcome of interest are shown here and previously were noted, and these are our variables of interest. We included all non-traumatic out-of-hospital cardiac arrest that were submitted to the CARES registry during our study period in states with 50% state-level CARES population catchment. We excluded out-of-hospital cardiac arrest that occurred in medical facilities or nursing homes, traumatic arrest, or arrest with missing values for any of our variables of interest. Our statistical analysis included descriptive data, chi-square and parametric testing, and regression analysis. Our study population included 291,388 total out-of-hospital cardiac arrest. 59% of these arrests occurred in states with laws enacted for high school CPR education. These are the general characteristics of our population, who were predominantly male at 64.5%, white at 50.3%, Black 17.3%, Hispanic 4.8%. The ages were less than 18, 3.1%. So while not common, this is not rare. Less than 50%, less than 50 years was 23.7%, and greater than or equal to 50 years, the majority was 76.3%. As you know, most arrests occur at home, 82.7%, public was 17.3%, but bystander CPR can have impact on both of these locations. Witness were 44%, and shockable rhythm 20.8%. We found that in states that had laws enacted, the rates of bystander CPR was significantly higher at 41.6% compared to those states with no laws enacted that had a bystander CPR rate of 39.5%. So 41.6%, 39.5%. Now this is an association, it's not a cause, but it is what we found. Further, we found, as we know, the hospital discharge and neurologically favorable survival follow the rate of bystander CPR. So in states that had education laws passed, there was a hospital discharge rate of 10.3% compared to 9.3%, and a neurologically favorable survival rate in states with laws enacted that was higher at 8.8% compared to 7.6%, and all these were significant findings. When we looked at gender, we found that bystander CPR was significantly higher in states, the laws are in green, in states with laws for both males and females, although males had better bystander CPR rates. And further, it was higher in states with laws for whites and Blacks, perhaps increased it to a greater percentage, but not as high for Blacks. But the ethnicity, perhaps because of the size of the population, was not a significant difference. We looked at the age by law status and found that bystander CPR was significantly higher in all age groups in states with laws, again, the green bars, except for this 13 to 17-year-old range. And that was the group that had the fewest arrests in the database when we reviewed it. So we looked at the adjusted relationship between law standard and bystander CPR and adjusted for the year of arrest, the age, gender, race, ethnicity, bystander witnessed, arrest location, shockable rhythm, and population density, and found that this still held that bystander CPR was higher in states that had laws. And again, the hospital discharge, although not as great an impact, and neurologically favorable survival was higher too, but there are other factors, as you all know, that go into this. We then looked at what the impact might be of social determinants of health, and we found that these had significant impact on rates of bystander CPR. We looked at the neighborhood characteristics of median household income, percent employment, percent Black, and high school education, and found that in states with laws that all of these increased. You can see the discrepancies still persisted with the lower income, lower employment, or higher unemployment, higher percentage of Black neighborhood, and lower education, all significantly having lower rates of bystander CPR. But in the states with the laws, this all increased. So we concluded that bystander CPR, hospital discharge, and neurologically favorable survival is higher in states with CPR and AED education laws, that this effect prevails across all ages, genders, racial and ethnic groups, and geographical areas, and that groups with lower SES have improvements through all domains of income, education, race, and employment status. We recommended that assistance to schools to help with CPR and AED education, especially in low SES minority communities, has the greatest potential for benefit, and that states with laws passed should enact them in a uniform fashion as soon as is feasible. These 11 states shown here are the ones that do not have laws passed or enacted, and we recommend that they pass those as soon as possible. So we wanted to look, having looked at these social determinants at what was known recently, and just 2 weeks ago, again, using the CARES registry data, the Garcia group published this information in the New England Journal on racial and ethnic differences in bystander CPR for witnessed cardiac arrest, and found that both for home arrest and public arrest, whites being the blue bar, that the bystander CPR was higher in those individuals, and this held across all income and neighborhood strata. Further, we thought, well, or they thought that perhaps the location of the arrest might be different because there would be different groups of people who could potentially provide bystander CPR, but they found that the disparities persisted through the workplace, recreational facilities, public transportation, in all locations. And they felt that this might reflect both implicit and explicit bias. They further looked at the survival outcomes, and the same disparities persisted in survival to hospital discharge and neurologically favorable survival, with this being lower for Blacks. You can see the adjusted odd ratios here than for whites. This information was actually looked at by Miriam Naim at CHOP using the CARES data again. A few years before, this was 2019, and she found that looking at median household income, so the higher median household income had higher percent of bystander CPR, the lower unemployment had a higher bystander CPR, the lower Black communities had a higher CPR, and the higher education had higher CPR. When one combined these with 1 or 2 or 3 or 4 of these characteristics, the amount of bystander CPR that was provided increased, so that the disparities in bystander CPR rates increased across all of these strata of income, employment, and education. Further looking at this, John Dresner and his group published information on socioeconomic factors and found that overall 51% of, and this is students in high schools, exercise-related sudden cardiac arrest, that there was a 51% survival of minorities, whereas whites had a 76% survival. They tried to drill down on this and look at the minority students and found as the number of minority students decreased, the survival increased. And then looking at income, they looked at the proportion as a proxy, the proportion of students on federally free or reduced lunches. And as that number decreased, the survival went up again. So there were, disparities both that related to race, ethnicity, and income. So we appear to need a multifaceted approach to bystander CPR and other sudden cardiac arrest outcomes. The barriers include the cost of CPR training, but that could be met by no cost or low cost training in local settings, schools, churches, and community centers meeting the community where they are. The barriers of language and cultural training issues could be to provide linguistically appropriate and culturally sensitive training. Language issues regarding CPR dispatch. If you're calling 911 and they don't speak your language, then everyone is out of luck. But if you have language specific, particularly they suggested Spanish and African languages and CPR dispatchers, that this could help to provide assisted CPR until EMS arrives. And then the barrier of a lack of trust in institutions, particularly the police, people concerned about their immigration status are not trusting EMS, could be met by engaging community, church, and other organization leaders to address the delays in calling 911 and increase the trust in institutions. I just want to talk very briefly about AED legislation. There's not much information, and this one paper published said that 20 states had AED laws, but they include Pennsylvania that had a law in 2001 that provided 2 AEDs to each of the 501 school districts and 30 intermediate units. But in the 20 ensuing years, they have not provided any additional funding, and many of the schools do not have AEDs, and we're trying to get an AED law passed in our states. But even of the 20, few states have fully funded school AED programs, even when they do have legislation. So the folks in Michigan looked at this because they had an AED law, and they found that larger student populations had fewer AEDs. So they would give an AED to a school, but just one when there was a large student population. Recommendation is 1 AED for 500 students or 1 per building. The higher minority schools had fewer AEDs per student, and we know that in most districts that property tax is what funds the majority of our school district budgets, so that when the property taxes are low, there is a lower budget to provide items such as AEDs. The lower SES schools therefore had fewer AEDs, fewer cardiac emergency response plans, and a lower AED maintenance. We think that the AED presence around the country is about 60, maybe in some areas 70%, but again, we don't have good data on that. But was Michigan just an anomaly? Well, Connecticut passed an AED in school law in 2009, and they did have a pre-legislation difference in private schools shown here in the black bar, and public schools that was essentially wiped out by the legislation. But small schools, they found, are still less likely to have AEDs compared to large schools. And interestingly, and unexplained, schools with disabled students you might think would have more AEDs, but they actually had less. And maybe this is just a problem in our country, but there's been a law for a while in Ontario, Canada, And they found many years after passing this law that only 70% who are supposed to have AEDs in the schools, and they're supposed to have CPR and AED in their curriculum, and only 6% of the high schools have AEDs. So there's a problem with implementation. We know that we need to have this legislation, and we should pass it with comprehensive model legislation, including AED placement, a cardiac emergency response plan, drills for schools, community organizations, sports groups and events, and CPR and AED training for students and school staff, including all coaches, as well as AED for first responders. In some communities, the police, who are often first at site, don't have AEDs. We need to institute oversight of implementation and help with facilitation. We need to require annual reporting from institutions, perhaps with some kind of consequences if they do not comply with the legislation. So in summary, the strategies to improve bystander CPR, AED use, and survival rates include prioritizing layperson education in CPR and AED use, including athletes, coaches, trainers, event support staff, and spectators, as well as the general population, to increase AED availability in public spaces, including sport and exercise facilities, improve the knowledge of AED location. There are apps such as Pulse Point, which will tell you where the closest AED is and notify you of an arrest. There are 911 units that will tell you where the AED, the closest AED may be as well. We need to ensure accessibility of public-facing AEDs with good signage that are not locked in offices. Develop a cardiac emergency response plan to provide rapid cardiac care, and disseminate this plan to all, including occasional users of spaces. We need to pass and implement these legislative mandates that I just mentioned: the AED placement, cardiac emergency response plans, and sudden cardiac death drills that practice cardiac emergency response plans. So in summary, laws can save lives with your help. So thank you very much.
Thank you so much for that amazing talk. It's quite a history and progress you've made over the years. I'd like to open the floor up if anyone has any questions for Dr. Vetter.
Who's going to win the Phillies game tonight?
I'm guessing you're going for the Phillies.
I wish I was going to the game. I will watch it, but yeah, I'm hoping. It was not a good night last night.
So I guess my question to you is, being an adult intensivist, where do you see the overlap between the research between pediatric and adult cardiac arrest? And do you see any projects that can kind of have overlap and work on improving the chain of survival for both?
Well, I think that, you know, adults are not in school, but their kids are often. And so I think if you support your child's school and their education, that there is some return on that. We're doing a study where we're asking students to take the little AHA CPR kits home and see how many friends and family they can train. But I think adult groups can support community training. Our adult group that, you know, Lance Becker led and now Ben Abella leads, to have a mobile CPR unit. They go out and they train people in the workplace. They go out and train people at various libraries, and we've worked with them, other kinds of health fairs and areas like that. So I think any opportunity you have to get involved in your institution's health outreach or community outreach would be great if you could support training in community areas. Some of our ICU intensivists have gone to churches and done taught CPR and as well as taught CPR on campuses. So medical students are, excellent trainers, and they like to be involved, not just with young people, but with older people. Amazingly, in senior centers, people want to know how to do CPR. And, I think that's great. A lot of seniors watch their grandchildren, we know now, and it would be really good if they knew CPR. Plus, if the grandchildren know CPR, then they can, help the grandparents. So it's kind of a two-way street. So I think that it's important to have a continuum where we go from the 4-year-old who can call 911 to the 90-year-old who can call 911 and do what they, need to do that's appropriate in that instance.
That's great. If there's any other questions, feel free to ask. If not, I think we can give everyone back a few minutes of their time. Okay, well, thank you so much for that wonderful Grand Rounds lecture. I know we all really enjoyed it.
Great. Thanks for having me.
Of course, have a good day. Thanks, everyone.